Committee will come to order. I'd ask unanimous consent that members not part of the subcommittees can participate in today's hearing. We want to thank you all for being here. Thank our witnesses. We'll do a quick opening statement. We'll introduce you, swear you in, and get right to your important testimony. And I'm not even going to read my prepared remarks here. I'm just going to say we all know how bad this crisis is. In 2016, 64,000 Americans died from overdose from an opioid, and it's hit certain areas of our country, as evidenced by the people we have here today, in a dramatic way. The ranking member came to me a few months ago and says, we need to have a hearing where we at least continue this conversation about what we can do to help improve this situation. I said, that's a great idea. Let's get folks together and do just that. So I want to thank our witnesses for being here today. I'm going to turn it over to the ranking member for some opening comments. And then, like I said, we will swear you in and hear your important testimony, and then get questions from members on the subcommittee and other members who have joined us for this important subject matter. So with that, I'd recognize Mr. Krishnamurthy for his opening remarks.
Thank you very much, Chairman Jordan, for allowing us to have this hearing today on this very important topic. I really appreciate your cooperation and the cooperation of your staff. And thank you all for traveling from long distances to be here today. And thank you to the audience, people in the audience as well. I asked for this hearing today because opioid addiction is a public health crisis that has devastated neighborhoods across Illinois and communities in every state. Local communities are at the front line of this crisis, and Congress needs to listen to them. Today, we will hear from local experts who are addressing the horrific impact of opioid addiction and other substance use disorders in Ohio, West Virginia, and in one part of my district, namely DuPage County, Illinois. In Illinois, there are an estimated 180,000 people with an opioid use disorder. Every single day, I feel the impact this crisis has on so many of my constituents in DuPage, Cook, and Kane counties. In DuPage County alone, 126 patients died of heroin overdoses and another 108 from fentanyl just in the last 3 years alone. I applaud the $3.2 billion in new funding for opioid treatment that Congress passed this year. But Chairman Jordan and I need to know, is the federal government doing enough about this disease? Is Congress supporting you in the most effective ways possible to address the opioid crisis? We need to know if you have the flexibility to respond to opioids, because what works in one area is not necessarily what works in another. We also need to know if you require more resources for prevention, treatment, and rehabilitation of those suffering from substance use disorders. We need to know if law enforcement is going after big drug cases and not just arresting addicts. We need to know if current law enforcement practices are preventing addicts from seeking treatment for fear of legal jeopardy. The public health crisis of opioid addiction demands that we are committing sufficient resources and that we are spending them efficiently and effectively. It is critical to increase the supply and use of the highly effective opioid overdose reversal drug naloxone so that we can save the lives of those who overdose. We must ensure that first responders and others have sufficient supply to prevent overdose deaths in their communities. I look forward to hearing today about evidence-based prevention efforts that have proven effective, including what we know about addressing the root causes of addiction, and that's something that's especially important to me. I want to know what's working in terms of preventing opioid addiction in the first instance. I look forward to hearing about effective harm reduction strategies for addicts with children in their household in order to lessen the burden addiction puts on families. Once addicts do come forward, there must be effective evidence-based treatment available to them, and they need to know where and how to find treatment. We know that various forms of medication-assisted treatment, or MAT, can effectively treat addiction, but current access to such treatment is woefully inadequate. Let me repeat that. Resources for that type of treatment is woefully inadequate today. Recovering addicts should have the tools and support they need to both get clean and stay clean. I hear about this problem in Illinois nearly every day. Even when people can get treatment, can get into rehab, they and their families still have no support upon release. It's not enough for us to just get them clean. We have to keep them clean. These people then struggle to maintain sobriety. I hope to hear today from our witnesses on ways to solve this problem. Finally, federal spending has to be held accountable. One of this committee's core missions, and I know Chairman Jordan agrees, is to identify and root out government waste, make sure that we're not throwing good money after bad. I look forward to hearing today how scientific evidence is being used to ensure that taxpayer dollars are being spent efficiently and effectively in local addiction response efforts. I hope today's hearing will provide a constructive conversation about what local communities are doing and what the federal government should be doing to address the opioid crisis and the disease of addiction. And I look forward to working with my colleagues on both sides of the aisle to address this public health crisis. Thank you so much.
I thank the gentleman for his opening comments. We'll introduce our witness. Why don't we start with the ranking member, and I'll let him introduce one of our witnesses who's from back in his district.
Well, thank you again, Chairman. Yes, I'd like to introduce our distinguished witness, Ms. Karen Ayala. She's the executive director with the DuPage County Health Department in Illinois, and she's the lead staff at the DuPage Hope Task Force, which she'll be talking about today. This addresses opioid prevention and education in my district.
Thank you. Now recognize the gentleman from, even though he's from Kentucky and going to introduce someone from Ohio, there's a relationship there. So the gentleman from Kentucky, Mr. Massey, is recognized.
As the chairman well knows, there's some good people in Ohio.
Yeah.
But we're always on the lookout for the Buckeye Navy coming across the Ohio River there. It is my honor to introduce the next witness. Thank you for allowing me to participate in this subcommittee. The next witness, Lisa Roberts, is a registered nurse from Portsmouth, Ohio. She's been working at their health department since 1989. And the city of Portsmouth, as the chairman knows, is located in Scioto County, Ohio. Drug addiction doesn't recognize geographic boundaries. And the area of southern Ohio, eastern Kentucky, and western West Virginia, that tri-state area has really been hit hard by opioid addiction. It's been the subject of some documentaries, but Lisa is at the forefront of fighting this. She helped form the Scioto County Drug Action Team Alliance, and she's currently administering the Drug-Free Community Program in Scioto County, which is in its 6th year. She oversaw Scioto County's first public health overdose prevention pilot program, and that's been a model for other communities in Ohio, as I understand it. But the most remarkable thing about Ms. Roberts is my mother was her nursing instructor, and she survived my mother's class, and I know she's been taught well. My mother taught me, and so it's an honor to have her testify here today.
Thank you, Mr. Massey. Good to have you with us, Ms. Roberts. Ms. Haskins is the Jackson County Anti-Drug Coalition representative from the great state of West Virginia. We're glad to have you here with us as well. And Mr. Siegel, who represents the Ohio HIDTA, High Intensity Drug Trafficking Area Program, and we appreciate you being here also. If you all please stand up, we have to swear you in, and then we'll get right to your testimony. Raise your right hand. Do you solemnly swear or affirm the testimony you're about to give is the truth, the whole truth, and nothing but the truth, so help you God? Let the record show that each witness answered in the affirmative, and there's a clock in front of you that you can see. It's 5 minutes. If you can keep your remarks within that 5-minute time frame, that's great. If you're a couple seconds over, we're not gonna hurt you or anything. And then we'll just move right down the list, and then, like I said, we'll get to questions. Ms. Haskins, you can go first.
Good morning. Chairman Jordan, Ranking Member Krishnamurthy, and esteemed members of the Subcommittee on Healthcare, Benefits, and Administrative Rules. My name is Amy Haskins, and I'm the Project Director for the Jackson County Anti-Drug Coalition, and also the Administrator for the Jackson County Health Department located in West Virginia. It is on behalf of our coalition members and the Jackson County Board of Health that I want to thank you for the opportunity to testify today regarding the Drug-Free Communities Program, which is housed in the Office of National Drug Control Policy. The Drug-Free Communities Program is the only federal prevention program that goes directly to communities to tackle the local drug issues. DFC provides training through the Institute to enable communities to implement substance abuse prevention strategies. In our community, DFC provided us with the tools needed to build capacity to achieve significant reduction in opioid use and misuse, despite the state of West Virginia having one of the highest use and misuse rates in the country. Not only did we reduce our prescription drug abuse among youth, but we reduced population-level rates of youth substance abuse across the board, not just prescription drugs. Preventing or delaying substance abuse is the single most critical tool in stopping the pathway to addiction and overdose. Research shows that for each dollar invested in prevention, between $2 and $20 in treatment and other health costs can be saved. Substance abuse prevention has historically been underfunded and underutilized in combating drug issues, including the current opioid epidemic. DFC has allowed our coalition to leverage other funds to provide prevention education within the school systems. It has also enabled us to respond and to address local trends as they arise. DFC has enabled our coalition to work on environmental strategies that create lasting population-level change and the ability to evaluate these changes through data collection. Specifically, we utilize the strategies of providing information, enhancing skills, providing support, enhancing access and reducing barriers, changes in physical design, and modifying or changing policies. Those environmental strategies are laid out in more detail in my written statement provided to you. With the training and technical assistance provided through the Drug-Free Communities Program and ONDCP, our coalition has been able to change the environment not only in our community, but throughout West Virginia. The destruction of medication from static collection sites is a tremendous issue across the United States. Our community determined what worked best for us and successfully advocated for similar changes across the state. The individuality of each community is what makes ONDCP and DFC such a marvelous program. Our coalition has significant community-wide involvement from our school system to law enforcement, local businesses, media, youth-serving organizations, faith-based organizations, healthcare providers, civic organizations, parents, and more than 100 youth, to name just a few. We determine through data collection and assessment what the best plan is for our own communities. In fact, looking at the latest PRIDE survey data for Jackson County, 4.7% of our 12th graders report using prescription drugs in the last year, nearly 6% lower in use as compared to the national annual use as reported by the Monitoring the Future survey. When looking at that same age group and the past 30-day use of prescription drugs, the national average is 4.9% as reported by the Monitoring the Future survey, while only 1.8% of Jackson County 12th graders report using prescription drugs in the last 30 days. Since receiving DFC funding, our coalition has been successful in reducing 30-day use among our high school students across the board. In fact, we have seen a 15% reduction in alcohol use, 13% reduction in tobacco use, 8% reduction in marijuana use, and nearly 6% in prescription drug abuse. The DFC program is a great example of how a very small investment of $125,000 per year of federal funds can inspire a great deal of coordinated and steadfast effort at the community level. Unfortunately, there is no one-size-fits-all solution to this opioid epidemic. But who best to determine what needs to be done to help a community than those who live, work, and raise their families there? I thank you for providing local communities like Jackson County, West Virginia, the opportunity and the ability to do what is best to keep our children moving forward with positive change. Thank you for the opportunity to testify before you today, and I'm happy to answer any questions you may have.
Thank you, Ms. Haskins. Ms. Roberts, you're recognized for 5 minutes.
Chairman Jordan, Ranking Member Krishnamurthy, and esteemed members of the Subcommittee on Healthcare Benefits and Administrative Rules. My name is Lisa Roberts, and I am the coordinator for the Scioto County Drug Action Team in Scioto County, Ohio. I have been a public health nurse in Portsmouth, Ohio, for 30 years. Portsmouth, located in Scioto County, is part of the Appalachian region that has been seriously impacted by prescription opioids since the mid-1990s. In 2010, Scioto County had the highest prescription opioid distribution rate in Ohio and the highest fatal overdose rate in the state at more than double the state average. We also had the highest rate of infants born with neonatal abstinence syndrome and numerous other community problems related to opioid addiction. And like so many parents, my own child developed an opioid use disorder at a young age and has struggled mightily with this disease throughout adulthood. It's been a long and difficult struggle for my family. In 2010, the county health authorities declared a public health emergency, and we formed a coalition. I have been the coalition coordinator since that time. In 2012, Scioto County was awarded both a drug-free community support program and a high-intensity drug trafficking area program. These two programs work collectively to provide comprehensive supply and demand reduction strategies across our community landscape. Thanks to the enhanced training, technical assistance, and programmatic support provided by the Office of National Drug Control Policy, I have been continuously professionally developed to guide this coalition's work. The combined efforts of these programs has resulted in numerous improved outcomes in our population. The DFC program has allowed us to regularly collect and measure youth substance use and behavioral data for the first time in our county's history. This information allowed our coalition to plan and implement locally tailored and evidence-based strategies designed to reduce youth substance use. Since 2013, these biannual data sets have documented significant and sustained reductions in youth substance use, not only for prescription drugs, but for all 12 measured substances, including tobacco and alcohol. I believe that these outcomes are a direct result of the DFC program and the training provided by the required year-long Community Anti-Drug Coalition Institute, which teaches coalition leaders like myself the essential processes to guide a highly effective coalition capable of achieving these types of successful outcomes. The Institute taught us how to use local data and to implement a combination of evidence-based strategies. These strategies are further detailed in my written statement that you have. The opioid epidemic remains one of the biggest public health challenges of our time, but public health receives little funding to address it. The current structure of the DFC program under the Office of National Drug Control Policy allowed my public health agency to be eligible for this federal support and to comprehensively address our local public health crisis. In addition to improving youth substance use rates, we have also seen positive secondary outcomes. Our prescription opioid distribution rates are at the lowest point in a decade, and Scioto County no longer leads the state in fatal overdose. Less infants are being born opioid dependent, and our high school graduation rates are now above the state average. And because we have built a community infrastructure that supports treatment and recovery from addiction, more youth are living in stable homes and more adults are achieving recovery. The federal investment of $125,000 annually provided by DFC has allowed our community to organize and work toward a better future for our residents and our children. It has also helped us to gain additional opioid-fighting resources, and these will be sustained into the future through the institutionalization of programs and services. In short, the small federal investment has seeded community recovery in Scioto County, Ohio. America's drug problems are extremely complex, dynamic, and ever-evolving. ONDCP is uniquely positioned to have a clear and broad understanding of these issues and how they can best be addressed through policy. These complexities require that we support an agency that has expertise and influence so as to provide national leadership and oversight to these issues. I believe it is critical that the DFC program remain in ONDCP and that this successful model is not disrupted. In closing, I want to thank the members of the committee for allowing me to testify on behalf of the critical importance of reauthorizing the Office of National Drug Control Policy and its vital programs. Because of them, we have been able to improve our community so that future generations of children and families can live safe, healthy, and drug-free. Thank you for allowing me to speak on this important topic, and I'm happy to answer any questions that you may have.
Thank you, Ms. Roberts. Mr. Siegel, you're now recognized.
Chairman Jordan, Ranking Member Krishnamurthy, and distinguished members of the subcommittee, I am honored to appear before you today to testify and highlight the Ohio HIDA, High-Intensity Drug Trafficking Area Program, or HIDA, and how the program assists localities in addressing the opioid problem. Today, fentanyl and fentanyl analogs account for approximately 58% of unintentional drug overdoses in Ohio. Opioids account for 86% of unintentional drug overdoses. Overdose deaths have risen 486% in the last 13 years, from 904 in 2004 to an expected 5,300 in 2017. We are seeing a rise in the seizure of crystal methamphetamine and cocaine being trafficked in large quantities by Mexican organizations. Recently, 140 pounds of methamphetamine was seized near Akron, Ohio. The foundation of the HIDA strategy continues to be the co-location of law enforcement personnel in order to increase information and intelligence sharing, provide training, and incentivize participation in uniquely effective drug enforcement initiatives. These collaborative efforts support HIDA's core mission of disrupting and dismantling drug trafficking organizations and money laundering organizations. The Ohio HIDA supports traditional drug task forces, along with highway interdiction, package interdiction, bulk cash smuggling units, and fugitive apprehension teams. Deconfliction services are a key contribution by the Ohio HIDA for all our law enforcement partners. Deconfliction prevents blue-on-blue incidents and duplication of efforts. In 2017, the Ohio HIDA deconflicted 4,200 law enforcement operational events and 72,000 subject elements for more than 300 law enforcement agencies. The Ohio HIDA participates in the ONDCP-sponsored Heroin Response Strategy, or HRS. The HRS is designed to enhance public health, public safety, and prevention collaboration, supported by 10 HIDAs across 22 states with the goal of reducing drug overdose deaths. The Ohio HIDA supports heroin-involved death investigation teams in our major metropolitan areas. These teams respond to overdose deaths and begin an investigation into the source of the drug. In July 2016, the Ohio HIDA began to train law enforcement officials throughout the state on an overdose incident form. Almost 10,000 overdose investigations have been entered from 42 of the 88 counties in Ohio, giving investigators the ability to instantly deconflict information. The Investigative Support Center spearheaded efforts to form overdose initiative groups within each of these counties. The purpose is to more efficiently link overdose data and enable intelligence support that otherwise might not have been available to them. The Ohio HIDA introduced the Overdose Detection Mapping Application Program, or ODMAPS, allowing first responders to report fatal and non-fatal overdoses and any administration of Narcan. The incidents are plotted on a map, allowing participating agencies to visualize overdoses in near real time. The Ohio HIDA participates in the Domestic Highway Enforcement Initiative, promoting collaborative, intelligence-based, unbiased policing on the nation's highways. Investigative support centers provide analytical help to participating and non-participating agencies, many of which do not have analytical support or record analysis capabilities. During 2017, the Ohio HIDA provided in excess of 15,000 hours of free training to more than 1,400 students, many who would not be able to attend training without the HIDA. HIDA has become more important as overdose deaths have doubled over the last decade, while drug enforcement funding overall has declined. Because of the reputation that HIDA has built for bringing individuals together and producing results, HIDA components are often involved with prevention, treatment, and education initiatives. HIDA executive boards are a key strength to the HIDA program. Ohio HIDA is managed locally by an executive board of 23 federal, state, and local partners who each have an equal say in how their HIDA prioritizes its efforts. As a program, not an agency, HIDA is viewed as a neutral partner whose goal is to help all levels of law enforcement reduce drug trafficking organizations and their effect in our communities. HIDA is best served under ONDCP, who provides leadership from a neutral, unbiased, non-competing point of view. ONDC possesses the expertise and authority to look at the drug problem holistically and set direction across the board. Thank you for allowing me this opportunity to testify before you today. I look forward to answering your questions.
Thank you, Mr. Siegel. Ms. Ayala, you're recognized now for 5 minutes.
I am both grateful and humbled for the opportunity to speak before you today. My name is Karen Ayala, and I serve as the Executive Director of the DuPage County Health Department. DuPage County is the second largest county in the state of Illinois. In this role, I have witnessed the heroin and prescription drug crisis unfold across our communities. and also instructed participation efforts to reduce the impact in our neighborhoods. I am oh so proud of our nationally recognized healthcare systems, as well as the most recent recognition of DuPage County as the healthiest county in Illinois. However, we are now in the 5th year of our response to this opioid crisis, and with the framework that has recently been developed through the HOPE Task Force, which is included in my written documents, I realize that we lack the resources needed to fully and successfully address this public health epidemic. I strongly believe, as we are faced with responding to the complex needs of residents affected by this pervasive and impressive public health threat, we need additional resources. So first, with the rise in direct-to-consumer marketing of pharmaceutical companies, coupled with the efforts of the drug companies to market opioids as safe, effective treatments for chronic pain, our culture has developed an unprecedented reliance on these medications while removing any perceived risk of harm or dependence. With that realization, the first opportunity for action by our federal partners is to review and to restrict the methods that pharmaceutical companies continue to use in order to increase the number of users of opioid medications. Until we are able to reduce the number of new users, we are waging a losing battle against this epidemic in our communities and across our country. The next opportunity to support our local efforts is to expand the critical need for access to effective and evidence-based treatment. Integrating behavioral health care with primary health care ensures the best outcomes for individuals with multiple health care needs. This integrated care, however, requires the unrestricted sharing of information between all members of the healthcare team. Currently, federal law, specifically 42 CFR Part 2, prohibits access to substance use disorder treatment, which represents a significant barrier. This regulation prohibits information related to substance use disorder treatment to be shared across all members of an individual's healthcare team. Earlier this year, the President's Opioid Commission identified this as an important component to address the crisis across our country. We and our DuPage County partners strongly support this recommendation and urge immediate action on this matter. Expanding treatment to all individuals in need represents a strategic focus of our local efforts. With an increasing number of individuals ensnared in this chronic and lifelong illness, treatment, in fact, represents hope and the opportunity to succeed. Currently, estimates indicate that only 11% of individuals experiencing substance use disorders are actually able to engage in treatment. Expanded publicly funded treatment opportunities must be achieved in communities across our country. Although I recognize this is a bold goal, I believe the utilization of existing networks that Congress currently funds and established through the federally qualified healthcare system, the community healthcare system, the rural health system, will assure this goal is achieved. Funding for this critical expansion of treatment must be allocated to achieve the additional treatment capacity we need in local communities today. Public health systems must be equipped to address this crisis and prevent others in the long term. DuPage County has been successful through the development of the HOPE Task Force multifaceted and comprehensive response plan. I am confident that our efforts to develop systems preventing substance use disorders while engaging individuals in treatment and recovery may serve as a model for other communities attempting to address this goal as well. These efforts, however, must be supported with federal assistance focused on developing new policies that reduce new opioid users coming into the system, easing of restrictions preventing the unrestricted flow of information across healthcare provider teams, as well as building the capacity through the expansion of treatment services from federal intervention. I look forward to continued partnership with you in these critical areas, and I wish to thank you once again for the opportunity to share.
Thank you, Ms. Ayala. We'll now go to Dr. Desjardins from Tennessee for first round of questions.
Thank you, Mr. Chairman. Thank you all for being here to discuss this very important and relevant topic. Mr. Siegel, I have a lot of questions for all of you, so if you can keep your answers short, that'd be helpful. You testified that ONDCP's neutrality is an asset to the HIDTA program. Can you elaborate on that for me?
Yes, the participation and oversight and guidance given by ONDCP versus a traditional law enforcement agency is actually a very good benefit. It is neutral. It does not make the state and locals feel alienated. It empowers the regional and local executive boards to make decisions in their area. And it, I think, has increased and continues the increase of the program because of the belief that they have a say in the program because it's not controlled by one agency. It's controlled and directed by the executive board.
Okay, and how does the reauthorization of the ONDCP ensure the continued success of the HIDTA program?
It places the HIDTA program under ONDCP and continues our operation under their coordination and guidance and funding.
Mm-hmm. How important is the ONDCP's national drug control strategy in shaping the focus of the HIDTA program?
It's very important, and it kind of goes both ways in that the drug problem started at a local or regional level, and all those combined feed into the national drug strategy, which ONDCP puts together. And by having HIDTA and ONDCP together, they can reach out to the HIDTAs across the country and have instant access to all the different drug information at the various, regional areas and cities and levels of law enforcement across the country.
Okay. Thank you. Ms. Haskins, the Drug-Free Communities Program provides federal funding straight to the local level. How effective is ONDCP, a federal policy shop, in administering a program geared towards local communities?
They are extremely effective. Something that is helpful with ONDCP being over the Drug-Free Communities Program is that ONDCP, their focus is substance abuse and abuse. So there is nothing else that is kind of clouding their focus area. They provide us technical assistance whenever is needed. They help us out if we have difficulty with our program officers or project officers through SAMHSA. They are there to help kind of connect us and help move that process forward.
Okay. The DFC program is required to collect and submit data about its coalitions every 2 years. How does this data collection ensure the effectiveness of your coalition?
We have to be able to prove that the $125,000 annually that we receive, that we are seeing reduction in use. Without that data collection, we're unable to do that.
Would it be helpful to collect the information on an annual basis?
I think there are some drug-free communities locations that do that. I think that in order to see long-term change, though, it's not going to be as effective to do it on an annual basis.
What does ONDCP need to improve its data collection, or does it need to improve it in any way?
The reports that we have to provide, it's once every 6 months. They provide a submission of what we have turned into them so that we have an overarching idea of where we're moving from and where we're going to. At this point, I would not say that there would be anything that would need to be changed.
Okay. Do your coalitions work with the HIDTA program?
We work with some of their officers in West Virginia. We particularly are not a HIDTA county, but all of the counties surrounding us are HIDTA counties.
Okay. Ms. Roberts, as Congress appropriates increased funding to tackle the opioid crisis, the need for federal-level coordination is imperative. How does ONDCP assist your local initiatives in preventing and reducing illicit drug use?
ONDCP has helped us tremendously to address supply and demand at the local level. Sometimes evidence-based practices and best science doesn't get transmitted to the local level areas, people so much. And so by allowing us to be exposed to forums, conferences, the leadership, the reporting systems, we're able to find out what is kind of the cutting edge types of things that's being science, that's being researched at the federal level, and we're able to take that to our local communities then and translate that into action at the local level.
How does the reauthorization of ONDCP affect the HIDTA and DFC grant programs?
Because they're both under the Office of National Drug Control Policy, these are their two main programs. Like Mr. Siegel said, it's very important that they be led by an agency that has very broad understanding. This is an extremely complex and evolving issue. And so it's very important for an office to be able to look at law enforcement's concerns, public health concerns, treatment concerns, and be able to kind of lead and develop policies that don't necessarily hurt another branch or another entity while developing a policy that helps another entity. So it's just very important for them to be able to have a very broad picture and to be able to translate that into information that communities like mine can use at the local level.
Okay, thank you all for your responses. I yield back.
Thank you, Doctor. The gentleman from Illinois is recognized for 5 minutes.
Thank you, Chairman, and thank you all for your really enlightening testimony. I wanted to first start out by saying representatives from 3 organizations, namely the Robert Crown Center for Health Education, the DuPage County Board, and the Gateway Foundation have provided additional testimony for the record about local efforts to combat the opioid epidemic in Illinois. Mr. Chairman, I request unanimous consent that this testimony be made part of the official record for today's hearing.
Without objection.
Thank you.
So ordered.
I'd like to start, I have several questions, so I ask everyone to please be brief, but first I'd like to start with Ms. Ayala. Thank you again. We're honored to have you here today. Ms. Ayala, how has the federal grant landscape shaped the work you're able to do with the HOPE Task Force?
So it was not part of my comments provided earlier, but we have been a recipient of the Drug-Free Communities Grant for the past 5 years. That, as the other members providing testimony, has provided us with an opportunity to coalesce a group and really provide the framework in which we can develop a more expanded approach based in the local community to meet our needs. Primarily, the efforts and the funding that we have received from the federal level so far have been around the use of naloxone, which we greatly appreciate, and it is very much needed within our community. However, one of the opportunities I think that grants such as the Drug-Free Communities and the HIDTA model provide is an opportunity for local communities to better define where their needs lie versus the categorical funding that has been historically provided to us.
Got it. Thank you, Ms. Ayala. Ms. Haskins and Ms. Roberts, with the drug-free communities grants that you've received, could you each just talk about a couple tangible examples of how you use that money to reduce the addiction rates in each of your counties? I was especially interested in Ms. Haskins' testimony about the reductions pretty much across the board. Could you talk about this, the tangible application of the money?
Absolutely. The very first year that we began our coalition, back in 2009, we had 16 youth die in a matter of 2 years, all pretty much from the same graduating class. So that's pretty difficult for a community to put aside and not recognize that we have a prescription drug issue. We were able to do a comprehensive public awareness campaign to help bring that forward and help kick off some conversation that otherwise was not being had in our community. We educated anybody from preschool all the way up to the elderly who participate in our senior centers. We had pharmacy students that would come in and volunteer their time to go over medications with the elderly and let them know what were some of the medications that were being taken out of the home, or watching mailboxes to take that medication out of mailboxes that had been sent through the Postal Service. So our comprehensive public education strategy was probably the biggest thing that we've done. We have also helped that money has also helped us utilize, like I said, the destruction of prescription pills. We have 3 static take-back locations that we advertise constantly. We usually get, we're a county of 29,000, and we usually get about 99 pounds of medication back per quarter. It is fiscally difficult to destroy that medication properly. So one of the things that we were able to utilize, only $2,000 of our federal money was to build and purchase an incinerator for our community so that we can destroy these pills and it won't be a financial burden on our community. We then took that idea and we advocated that that needs to take place throughout the state of West Virginia. So therefore, we now have regional incinerators throughout the state of West Virginia to help other small communities like our own. You know, when you do public education and you are going into the classroom and you're teaching kids, you're teaching parents what to watch for substance abuse, you're teaching teachers what substance abuse looks like so that they can understand, you know, when kids are high in the classroom. We've done law enforcement training to train them on diversion, because when we started seeing pill issues in our county, law enforcement didn't have a clue. They don't know if it's a blood pressure medication or if it's an oxycodone. You know, so those types of trainings were very important, and our DFC funding enabled us to do all of those skill building opportunities. And that's how we ended up with a reduction across the board, was all of our educational opportunities that we're able to provide.
Thank you. Can Ms. Roberts answer
Sure.
briefly? Ms. Roberts, can you please address the question?
Yes, our DFC funding enabled us to do comprehensive strategies across the entire community. And one of the requirements of drug-free communities is that you have a very broad sector representation. There's 12 sector members that are required to be part of the coalition. When we first started our coalition in 2010, we were actually in incident command mode, which is a public health military type of strategy that's used for an emergency, which we had declared an emergency, but we needed to learn to be more strategic and long-term and have outcomes that were going to last over a period of time after the urgency subsided. So sector leaders ended up being very important. One sector leader in particular is a healthcare provider. Our healthcare provider at the moment is our health commissioner, who is also a DATA 2000 waivered physician, and just the coalition inspired him to become a board-certified addictionologist. And so those strategies allowed us to have access to prescribers, the people that are actually writing prescriptions. And so we were able to get into hospitals and medical societies and dental societies and things like that, and tell them about the opioid crisis, which they weren't aware of at the time in 2010, but also to change their prescribing habits, prescribing guidelines to increase their access or utilization of the prescription monitoring program. And so in my written testimony, you can see that we are at the lowest point since the prescription monitoring program began in terms of opioid prescription being written. Thank you.
Thank you.
If you could do just one thing and only one thing, what would it be? The single one thing you would do to deal with the problem?
One thing.
Ms. Haskell, I'm just going to go down the line.
Okay.
I would
Single most important thing to address the problem in your community or your community across the country, what would it be? Only one thing.
I would have to put in place some type of parameters for the MATs that are in our area, for the medication-assisted treatment programs that are in our area, for the adults. For youth, it would be absolutely prevention, prevention, prevention.
Okay, that sounds like two things. Ms. Roberts.
Well, in terms of the overall, drugs are always a symptom of a bigger thing. And so we, you know, Appalachia has been an area that's kind of been impoverished. And so I think that overall, anything that can improve the economy is going to be helpful in the long term. But I would have to say at the moment that this isn't necessarily being treated like a public health emergency, even though it has been declared. Whenever there's a public health emergency, there is typically a stabilization period where the crisis kind of gets contained. And having been through multiple addiction treatment facilities with my own child and experienced a gamut of things that did not work. My daughter thrives on medication-assisted treatment, but I cannot tell you how difficult that was for me to access for her. So I think that I would have to say I would like to see our regulations surrounding medication-assisted treatment be lessened, similar to what some of the other countries in Europe are doing. People can actually dose on methadone at a local pharmacy on their way to work. I don't have any access to methadone in my community. The closest clinic is like 100 and some miles away, and so that would be my answer. Thank you.
Thank you. Mr. Siegel.
Yes, I would, if I could do one thing, it would be the continuance of HIDA under ONDCP, because as I stated, it allows us to operate efficiently and effectively and also interface and support the prevention and education and treatment sides more effectively. For instance, some of the items I mentioned, like OD maps, that's not just for law enforcement. We developed it for law enforcement, but it's open to hospitals, treatment people, other people, public health people to see where the overdoses are occurring. Yep. And some of the HIDAs are starting to use that information to forward out to the treatment people to say, hey, we have responded to this individual 5 times or 3 times. They've been Narcaned X number of times. You may want to get out and talk to these people because they're going to be your next overdose victim. But I think that totality of a strategy that ONDCP encompasses allows us as an enforcement program to partner and have greater access to the areas and provide assistance in those areas.
Ms. Ayala?
My recommendation would be integrate and expand access to substance use disorder treatment across the community with a particular focus on individuals who are uninsured or underinsured using public funding for their care.
Do any of you believe that other social welfare, not other, but social welfare programs, government programs in our social welfare system, I should say, do any of you believe that there's a study done by Senator Johnson's staff over on the Senate Oversight Committee, where and there have been some research in this area, that the Medicaid expansion is actually in some ways maybe contributed to growing opioid use in certain communities. Do you think that is something that should be examined and may in fact be the case, Ms. Haskins?
I will not blame that for the reason that West
I'm not saying
has had an increase.
I'm not saying cause and effect yet, but do you see a correlation and potentially cause and effect relationship between the Medicaid expansion and the opioid epidemic?
I believe it has made it easier for access. Yes.
Yeah, that's what our Senator Johnson's study indicates. Ms. Roberts?
Ohio is one of the states that did expand Medicaid, and so I can probably speak on that a little bit. However, Ohio had a prescription opioid problem before Medicaid expansion. What Medicaid expansion...
I'm not. If I could interrupt for a second, I'm not
Yep.
saying it didn't.
Yeah.
I'm asking, do you, as a professional in this area, do you think the Medicaid expansion exacerbated an already existing problem?
I think Medicaid expansion helped tremendously in terms of the problem because it allowed access. What I see at the community level is that it allowed access to addiction treatment for a lot of population that was not able to access it.
Do you think
before.
welfare reform would be a necessary part of actually addressing this overall problem? Reforming our welfare policies, incentivizing work, doing different things. You mentioned in your comments earlier, Ms. Roberts, that economic concerns you think led to this. So do you think reforming our welfare system would help with this problem as well?
I think that it would be worth taking a look at, but as far as where I'm from, there really aren't a lot of opportunities for people, and so public assistance is necessary for those people. So I was speaking more in terms of economic development and opportunities.
Ms. Haskins?
I would say absolutely. I mean, I would agree with that. Yes. I think part of what would need to happen though is with the Medicaid expansion, much like they would need to be able to go across state lines to access treatment.
I'm pushing my limits on time, so I'm going to recognize Ms. Kelly for her 5 minutes of questioning.
Thank you, Mr. Chair, and thank you and the ranking member for having this hearing, and welcome to all the witnesses. I have another question that I had planned to ask, which I still will, but maybe I missed this. When you think about your places that you represent, or even if you think about nationally, how did this start? Like the majority of the people that have opioid addiction or died, how did it first begin?
If I could jump in. Within our community and within our research, we work closely with the National Safety Council, and what their evaluation demonstrates is that 75 to 80% of the individuals who are currently addicted to heroin began their journey into this complex world through the use of opioids prescribed by their physicians.
Thank you.
Or doctors.
I would tend to agree with Ms. Ayala. I would also say that West Virginia had a very high heroin usage rate, and when that balloon started to get contracted on the heroin side, it's going to automatically flip over to the opioid side. You know, our particular issue in our community was fentanyl, way before fentanyl was a household name. Mm-hmm. And that was coming from local prescribers.
Thank you. Anybody else?
I'd like to chip in. I'm from Portsmouth, Ohio, which was we ended up with a lot of notoriety for being an area that saw the opioid crisis really early. We were making headlines back in 2002 in terms of OxyContin. And so these products were marketed heavily in Appalachia, you know? That's why they ended up being called hillbilly heroin. And so I would say the pharmaceutical company marketing played a role in that, but also what we saw was that it became a form of currency in an impoverished area that where people didn't have access to other forms of making money. So I think these things were interrelated.
I have to be careful. Both the ranking member and I are married to doctors, so I have to be careful. And my husband is an anesthesiologist. But that's what I thought. And when I went to a meeting with my hospital where I represent in Illinois, they actually started a program where they gave out the medicine to prevent the deaths, but that was something they talked about, more education for the prescribers, that was needed too. But anyway, again, I want to thank you. I wanted to talk to you about access to the life-saving drug naloxone. As you know, it's a drug that reverses opioid overdoses and prevents death. And last week, the Surgeon General issued the first advisory in 13 years calling for expanded access to it. He wrote that increasing the availability and targeted distribution of naloxone is a critical component of our efforts to reduce opioid-related overdose deaths. Ms. Roberts, I understand you're a registered nurse, and you've obviously worked in the public health field for a long time. So I'd like to ask you, is access to this critical for first responders and others working on the ground to save lives?
Well, as someone who has worked extensively with the drug naloxone, I think I can say that it is absolutely imperative, especially at this time when we're having a national crisis. But naloxone is a prescription drug, and so therefore it's subject to all of the rules and regulations that surround a prescription drug. In some other countries, it's not necessarily, it's an over-the-counter drug, and so it's you know, sold over the counter, it's very cheap and all of that kind of stuff. So it is a little bit difficult to navigate the system sometimes because of the rules and regulations that control it, as far as who can dispense it, who can you know, prescribe it, and all of those things. So we have, in Ohio, we've actually had to navigate that system for several years and have managed to be able to get it to a point where we're able to have it available at certain pharmacies through a corporate protocol. There has to be a licensed prescriber in the loop someplace, which makes things a little bit difficult. And so we have been able to get it to where, you know, people can get it without a prescription by going to a certain pharmacy, and it is covered by insurance. However, as far as supplying it to law enforcement and fire departments and these sort of non-traditional first responders, the fact that the price does increase frequently, you know, really does kind of impede we kind of fly by the seat of our pants all the time in terms of coming up with the medication.
Well, and mentioning that, several of my Democratic colleagues did write to President Trump in September of last year asking that he take action to lower the prices. And this morning, actually, Ranking Member Cummings sent yet another letter to President Trump urging him to adopt his own commission's recommendation to negotiate lower prices and ensure that this life-saving drug is available to all who need it. I know my time's over, so thank you.
Thank you. Chair now recognizes the gentleman from Kentucky for 5 minutes.
Thank you, Mr. Chairman. Ms. Roberts and Ms. Haskins, I represent a very rural district in Kentucky that has been hit especially hard by the opioid epidemic. How have you seen the opioid epidemic uniquely affect rural communities?
Especially in our community, much like Ms. Roberts said, it is a form of income for a lot of people in a location where there are no other jobs. Luckily for us, with DFC funding, we are able to do some prevention with the children of those families and parents who are using a lot and abusing and selling. Helping them create goals and figuring out that there are some other options in life other than utilizing prescription drugs or some other form of a substance. In particular, we have many of our elementary schools in Jackson County that are seeing difficulties just now with students coming up through the school system. They cannot retain information. This is pretty much the first wave of children who are coming through the school system from opioid, they are opioid-exposed babies. And they are having difficulty retaining information that's being taught. That's not the fault of the teacher. That's not the fault of the school system itself. And we don't know how to deal with these children because they can't get qualified for special ed. They're not learning disordered as far as what the school parameters are. So we're having difficulties even with behavior in our school systems. That's probably one of the most recent happenings from how it has affected our community.
Right. In answer to your question, I've seen opioids affect our community in so many negative ways. And so prescription opioids really just sort of set the landscape in Appalachia. We had never really had a heroin problem. Heroin was a problem that was associated with big metropolitan areas, and so heroin is now a problem in Appalachia. And because of that, we're absolutely seeing children who are, having to live in families where substance use is a problem. However, the Drug Free Communities grant has allowed us as a coalition to address parental substance use. Because that has such a negative effect on children. One of our sector leaders is the juvenile court judge, and he actually has started a family drug court to help families that are struggling with opioid use disorder so that they can retain their children and keep the family intact.
One of the things that Chairman Jordan mentioned with the expansion of Medicaid is that the question he asked was, did that make the opioid epidemic worse? And the source of most of the opioids in my rural counties, according to my law enforcement, from people on Medicaid, for what you mentioned, a source of income. Absolutely. And that's something that, you think about it, that's being paid for by the tax dollars. That's not coming in from drug cartels. That's coming in from citizens in the communities that are getting free prescription drugs and turn around and selling them, which is having devastating effects on a community that's already been devastated by the new economy. So that's something that I think we need to look into. And do you have any advice on how to prevent that? Alternative sources of pain relief. I mean, I don't know. There's certainly overprescribing that's going on in rural communities.
In our particular community, at this point, I don't think it's an overprescribing issue. It truly is an access issue. we have a needle exchange program that we just started in our health department, and I can tell you that most of our individuals that come through our program are actually using Suboxone and Subutex and crystal meth. You know, so again, access is an issue. I think one of the main fixes would be to have some additional quality mental health counseling available, because right now in West Virginia that is seriously lacking, and I'm sure it would be similar in Kentucky as well. Okay. Because until you deal with the root of the problem, and you know, most people will tell you that with substance abuse there is some underlying mental health issue that's not being dealt with, they're going to continue to use.
Okay. All right. Thank you, Mr. Chairman. I yield back.
Gentleman yields back. Chair now recognizes the gentlewoman from the District of Columbia.
Thank you, Mr. Chairman. I particularly thank the witnesses who testified, whose testimony has already clarified much for me. I want to make sure I know what we're talking about. I think it was you, Ms. Ayala, who talked about how people on heroin transition to opioid addiction. One of you did. And I think it is useful that we are using what looks like a broad term to describe what we're talking about. When we hear substance abuse, sometimes is a term used. But I'd like to know essentially what we're dealing with. One of you indicated, or perhaps it was my colleague, that it was called hillbilly heroin in his rural area. Well, obviously it's not called that in mine. I represent the District of Columbia. And big cities are where you've had heroin abuse. Now you have something else, and it looks like physicians and the medical community is implicated. And so I'd like to know exactly what we're talking about. When we talk about an opioid crisis, most people will think that's prescribed or hijacked medicines. I don't think they understand the relationship to heroin. So anything any of you could do to clarify that, I think would be useful for this hearing.
I'd like to clarify that. Prescription opioids are commonly called pain pills, painkillers. They are manufactured by pharmaceutical companies, and they have some molecular structure that includes morphine.
No, I understand that there's a difference between the stuff. I'm trying to find out how these substances why you find some in some place, some in the others, why there's a crossover, even if you think that there are hillbilly heroin in some places. Was any heroin there before?
No.
I don't understand how this got started. I don't understand whether it's sectional, whether we need different approaches for different parts of the country, since apparently they all transition between and across one another.
Molecularly, heroin and prescription opioids are very similar. So you can kind of think of them as being interchangeable. When somebody becomes addicted or dependent to prescription opioids, then heroin will fill the same need. It's also cheaper, comes from a different place. So
now, heroin is cheaper.
Absolutely.
How do people get how are people, since initially opioid has to come from a physician, I guess from a prescription, how does that get to be like heroin so that it's simply passed all around the community?
Well, prescription opioids come from a physician, and they've been used widely for the last 20 years due to some changes that took place with something called a pain scale. There was a belief that we were under-treating pain in the United States, and so you saw prescription opioids, especially some very potent ones, come on the market and end up being very liberally prescribed. When I mentioned earlier that
so liberally prescribed. Now, all right, I get a prescription. I go around selling that prescription. Is that really the only way people are able to market this as a drug? They keep going back. Where do they keep getting the prescriptions from?
Well, they can find a prescriber that will give them the prescription. And so there's
So it looks like Congress or somebody needs to do something.
So if I could just interject, the prescription drug monitoring programs that have been established on a state-by-state basis have been very successful in addressing the multiple attempts by an individual to go to multiple prescribers and game for additional prescriptions. However, the flip side of that is once that source is diminished, then that individual tends to turn to street heroin, both because of the availability as well as the price. So that happens on a system-wide basis, but it also happens on an individual basis.
Yeah, that's important to understand how that occurs. They become addicted, whether with heroin or opioids. It doesn't matter. They're addicted. Now, Governor Christie of New Jersey headed the President's Commission on combating drug addiction. And I just want to read to you what he said to find out what in the world Congress needs to do. Because this is a crisis that's getting worse. This doesn't always happen. I mean, there was Ebola crisis. That was very different, but we got a hold of it. Swine flu, we got a hold of it. This thing is running away from us. Governor Christie said one of the most important recommendations in this final report is getting federal funding support more quickly and effectively to state governments who are on the front lines of fighting this addiction. Do you believe this is the key to quelling the addiction you find in your communities? And I'd like to have answers from all of you. And increase funding from the federal government.
Absolutely. Increase drug-free communities funding, because that is letting local communities deal with whatever trends are coming through their communities. It's not a it's not a one size fits all answer, unfortunately.
Ms. Roberts?
I would have to agree with Ms. Haskins, and I can't. Drug-free communities is extremely important. It does allow you to be fluid and to shift your focus when necessary, and the opioid epidemic is a good example of when that has happened. We had prescription opioids, kind of dealt with that, took care of that, and then now we have a heroin problem. Many federal grants are very restrictive, and they'll say, well, you can only deal with prescription opioids. So what do you do halfway through? When a heroin problem comes, you're kind of stuck. And so drug-free communities is very important because they allow us to be to kind of shift gears midstream when we need to, along with the HIDA program because supply reduction is extremely important now too.
Gentlewoman's time's expired. The chair now recognizes himself for 5 minutes. Ms. Roberts, I wanted to follow up with you. Chairman Jordan had asked you about the Medicaid expansion. There's been some testimony for the Congress and some data suggesting that has fueled the epidemic, and I think the argument is, you're expanding to able-bodied adults. The program is not really good for long-term quality care and things of that, but it does provide access to the prescription drugs. And so the stats, I think, are 13 of the 15 states with the highest opioid overdose rates are Medicaid expansion states. I think your testimony was you think it's helped mitigate the problem, not exacerbate it. And so what is your basis for saying that, and have you seen data that would that would substantiate your view?
Well, thank you for the question. I think so they're saying that prescription opioids become more liberally prescribed in states that expand Medicaid because now people have more Medicaid and have a way to access them. Am I correct? Is that what's being said?
And I think it's, you access it with, I think, pretty much no cost to the patient.
Yeah. And there could very well be some truth to that, but what I can say about Ohio is that Ohio did not expand Medicaid until probably 2014 or 15. Our prescription opioid, at that time, my county had the highest distribution rate in the state of Ohio. So we had plenty of opioids before Medicaid expansion. What I saw Medicaid expansion do for Ohio was allow many of the people that we were not able to help get access to addiction treatment. So I think it's just probably going to be one of those double-edged swords.
Right, because I think some of this, the graphs, since 2013, you've seen, it's noticeable, the increase in the Medicaid expansion states. Let me ask you this, is the bigger problem too many prescriptions and abuse of that right now, or is a bigger problem the street drugs?
Well, that depends on where you live.
What's your experience?
Well, where I live right now, the bigger problem, we have seen almost 100% transition to heroin, and that happened relatively quickly when the prescription opioids became less easy to access. We have seen the analog drug fentanyl products show up in heroin, and now they're showing up in other illicit drugs such as cocaine and crack. And so we're starting to see our entire drug supply become contaminated with these analog drugs that are highly lethal.
Where is that coming from?
Primarily, it's coming from China. There's been many labs that have been...
China sends it where?
It's a very condensed product. It's very small, so it's very easy to send in the postal system. And so it can be mailed to different parts of Canada and driven across the border. It can also be mailed to the United States.
Well, I think that's true, and it's interesting. They won't use Federal Express or UPS for that because it will be identified. The post office is at a tough time. We passed a bill recently to try to provide some tools to deal with that, and so it does come in the mail, but a lot of it, comes in, across the border. And I think that if you look at this crisis, it does. It's shot up around the same time where we've had a lot of problems at the border, and I think that there's issues with what taxpayers have to shoulder when we don't have a secure border. There's issues with the rule of law that are very important, but this drug issue is a huge deal, and this garbage is coming into our country. And I think the prescription stuff, obviously has been an issue, still is, but the prescriptions are going down now, and yet this stuff out there is just absolutely killer. So we've got to get a handle on this, and I'm all for treatment. I'm all for fighting it on the demand side, but you got to fight it on the supply side as well. There's no way you could just let our country just be an open field for this stuff and not think that we're going to have some really negative consequences. And with that, my time's expired, and I will recognize the gentleman from Wisconsin for 5 minutes.
Okay, we have a few questions here for the experts. We've heard how much the opioid crisis has gotten, and it has gotten much worse. And of course, we're spending billions of dollars between law enforcement or treatment or whatever. Are there any examples around the country of states or large or small municipal areas in which there has been a precipitous drop in the number of deaths caused by opioids that we could say, these people know what they're doing? Are there any examples of that around the country?
I think in Huntington, West Virginia, they would be a good example. The health department there started a harm reduction program. Their issue is mainly heroin. They have provided, thousands and thousands of doses of naloxone, and they have seen those drop.
And how big is Huntington? How many people live in Huntington?
I would say probably about 70 or 80,000.
Okay, and do you know,
that's a large metropolis in West Virginia.
Okay, yeah, I know, I got a district like that too. Like how many people, okay, so there wasn't even a reduction in the use of the opiates. It was really just, they got the shot to a lot of these people in time, right?
Yes. But now, as far as reduction in use, I think you look at any drug-free communities grantee program recipient, and you will see a reduction in usage rates in their areas.
Yeah, can you give me an example of a city that if I look up or call their county, there has been a drop of deaths and it's attributed to a drop in usage?
Well, I mean, if you look at Jackson County, West Virginia, we have had a drop in overdose deaths.
Okay.
Among adults and specifically youth.
Okay, next question I have in general. One of the tragic things about this opioid epidemic is it strikes very good families, however we describe good families. And it just must be shocking for parents who did everything right and have this happen. Nevertheless, I always do wonder about overall statistics on family background of people who wind up in this situation. Do we have any statistics on that?
On family backgrounds?
Correct.
No, but I mean, science has proven that if you have addiction somewhere in your family tree, you are almost 50% more at risk to have an addiction.
Right. So we have no.
If I could add,
sure.
Most of our information is anecdotal and is geographic. and demographic dependent, meaning whatever the representation of the community, that's what we're seeing reflected in the overuse and death data. So for DuPage County, Illinois, the vast majority of our overdose reversals occur to young white males between the ages of 19 and 29 years old. That also happens to be the largest demographic in our community. So it is one that is absolutely, it is absolutely agnostic when it comes to.
Let me cut you off because I only have so much time. That's kind of meaningless if you say the largest demographic has the most deaths. That's kind of expected. What I'm wondering is, are there any studies out there, given the sea of money we're throwing at this, who can give us some statistics on family background or parental background on that sort of thing?
By the time an individual gets to the point of being addicted, many times they do not enjoy the support of their family, regardless of where they started.
Well, yeah, you're not answering my question,
Okay,
though. I'm
sorry.
sure that's true. Do we have any statistics?
We do
on-
not.
Okay,
Not that I'm aware of.
Do you think it'd be a good idea to get statistics like that, given the gravity of the problem? It would be. Okay. Next question. One of the benefits of your program is that you have flexibility to do different things in different counties, right? Can you give me a solid example of how you should do one strategy in Huntington and a different strategy in another type of city? Or any city. You know, one of the reasons we're talking about this program being good is that you can adapt locally,
Right.
which presumably means it's not one size fits all. So I'm looking to kind of give you a softball question in which you guys can tell me, you know, we did this in this city and it worked, but it wouldn't have worked in this city where we did something else.
Well, I can tell you, for example, Huntington, West Virginia, they began the harm reduction program. They offer naloxone classes once a week. They give out thousands and thousands of doses of naloxone and save lives every day with that. In our particular community, an hour north of Huntington, naloxone would not help in our community with what is being utilized at this point. Because what's being utilized by our adults at this point is Suboxone, Subutex, and meth. Naloxone's not going to save your life if you're using one of those three things. So,
I guess, are there differences by community other than just the type of drugs that are being used?
absolutely. I mean, the way that, other than socioeconomic, I mean, the way that your communities are structured, we have wonderful relationships with our Board of Education, with our law enforcement, with our local city councils and mayors that come together for this issue, whereas Huntington may not have that type of partnership with their organizations and their movers and shakers.
In Cleveland, Ohio, the medical examiner's been pretty active in putting out statistics and things that he sees, and it's kind of back to your question, but he has found that in the Cleveland, Ohio area, which is Cuyahoga County, which leads the state in overdose deaths, that what he has seen is primarily white males in their 30s and 40s, but there's a correlation between their education level and most of them work in the trades. And I think that when you say they work in the trades, I think that's back to the pain pills that started because, you know, their back hurt or something got hurt as they're working on one of the construction trades. So there seems to be a push to educate and reach out to those trade unions to help educate their members.
When I said background,
Gentleman's time is expired. I now recognize myself for questions. I want to point out, I want to ask Ms. Haskins, you talked about children with the learning disabilities or
Yes, sir.
other issues, or children and parents who are addicted to opioids. Have you seen any disparity demographically between children of people who are enrolled in Medicaid versus children who are not enrolled? Is there a greater population of children with these issues who are from homes where the parents are on Medicaid?
I would have to look at the school system for that, but just anecdotally, from what we hear in our community and from my observation, A large number of the children that are in that situation are certainly parents who are either uninsured or on Medicaid. But having said that, we also have a lot of children who are being raised by grandparents whose parents are very financially well off and able to provide whatever it is that they want, but because of their addiction, they're living with family members.
I understand, but the point that, and you've verified it, and it's consistent with the data that I've seen. There was a CDC study in Washington State that showed that persons on Medicaid are 5 to 7 times more likely to die an opioid-related death than someone not on Medicaid. You also see it that the opioid prescription rate among Medicaid enrollees is at least twice the rate for persons on private insurance. So you would naturally look at that data and conclude that some of the issues that you brought up about children having these learning disabilities would disproportionately come from households where they're on Medicaid. And I think that's a real issue with this. Mr. Siegel, Ohio enrolled more than 700,000 adults in the expansion of Medicaid and is now seeing an unprecedented problems with opioid addiction. As a matter of fact, last year Ohio was on pace to have more opioid-related deaths than the entire United States did in 1990. That's one problem. I also want to know if you've also seen more trafficking of opioids from true Medicaid enrollees.
I don't know if I have any basis or statistics to support that one way or another. Most of the HIDA-funded counties in Ohio are centered in the major population areas. We only have one task force that operates down in Portsmouth in a rural area. And so I don't see, most of what I see coming from our interdiction efforts and enforcement efforts are in the larger metropolitan areas. And we're in 17 of the 88 counties, 14 of the 88 counties in Ohio. So in those rural counties, I really don't have a basis.
Well, it wouldn't be rural versus urban. It's more, are people getting prescribed opioids and then selling them? Is it, there are a number of issues here that are related to this, but we're seeing this across a number of programs where there's trafficking, whether it's a SNAP benefit card or an opioids that someone got as a result of a Medicaid prescription.
We're interdicting less pills and seizing less pills than before. Most of what we're getting now is the fentanyl, and it's actually overtaken heroin. So if you want to make a correlation, I don't know if you can, between less pills and more people on Medicaid getting pills, but we're seeing and seizing less pills.
Well, you mentioned fentanyl. It was recently reported that there were 3 people arrested who had enough fentanyl to kill everybody in Toledo. In my district, there was a gentleman arrested who had 38,000 lethal doses of fentanyl that he bought on the dark web and paid for it with Bitcoins. But Ms. Roberts, you're talking about it's produced in China. I would also add that the North Koreans are doing this. I was in a field hearing at Johns Hopkins Hospital with the former governor of New Jersey, Chris Christie, and I asked him if we've gone from a war on drugs to a war with drugs, and that the 70,000 or so people who have died from overdoses, are they casualties of this war? But it was interesting to me that when you talked about how it gets into the country, it comes in the mail, but it's largely coming across the border. And you only mentioned the Canadian border, and perhaps that's because Ohio shares a border with Canada. But I do think that this is the real issue of border security. And a lot of people lose sight of this, that we're in a war with drugs, and it's coming across the border. And the fentanyl issue, I think, is something that we're going to have to address outside of just drug policy, because it is lethal. Any comment on that? And Mr. Siegel, if you, in your efforts, where you
I would agree with you. It is coming across the border, and some of that is coming from China to Mexico and then up. And there's also a strong belief that the Mexican drug cartels are starting to produce their own fentanyl and transporting it up. But fentanyl, heroin, cocaine, all the major drugs are coming up from the southwest border into Ohio and most of the HIDAs. There's very little activity from other parts of the world. Some of the East Coast still see some from the Asia part of the world, but most of it's coming up through Mexico, at least in the Ohio HIDA.
Well, one last issue here, Ms. Ayala, is I've raised this question in the field hearing as well about the fact that hospitals have quality surveys that they provide for their patients, and one of those was on pain management. And when you're tying the federal government's reimbursement rate to the hospitals or to physicians based on the outcomes of these quality surveys, and you include pain management, that creates an incentive to over-prescribe. And I think we can't address this whole issue of opioids without addressing that. And it's my understanding, and I hope they're doing this, that beginning the first of this year, they removed that as one of the criteria. Do you have any information about that? Any of you know anything about that? Have you seen any changes in that?
That is my understanding as well from our own Senator Durbin's staff. That is our understanding. The issue, however, is still with patient satisfaction. It may not be directly tied to pain management, but if I went to the doctor with the expectation of getting an opioid prescription and I left without one, then my satisfaction in general is going to be decreased. So I think that your point is right on, and we need to do additional kinds of analysis around those policies.
I would like to thank the witnesses again for appearing before us today. Are there any other members you wanted to ask one? Recognize the gentleman from Illinois for one question. Is that?
Two questions.
Two questions. All right.
Thank you, Mr. Chair. Okay, two final questions. One is a very tangible question based on what I've been hearing, which is I think each of you have kind of developed a program or strategy that was effective in combating the crisis. If there's one thing that you could share with the rest of the communities who are paying attention to this hearing, or the others who are paying attention, what would it be? Like, what would be the most effective thing that you did in kind of dealing with the opioid crisis in your community?
I would say looking at data, analyzing, and figuring out exactly what the root of the problem is.
Okay, thank you. Ms. Roberts?
I would say learning how to think strategically and long term, such as what's taught at the Community Anti-Drug Coalition's Institute, which we went to, which changed the way that we dealt with this altogether, and the importance of data and being able to monitor, and like Mr. Siegel said, live monitoring. You know, data that's a couple years old isn't real useful. So I would say that drug-free communities actually taught us how to do all of those things.
Great. And Mr. Siegel?
I think the bringing of all the levels of law enforcement together, but also developing those systems that I talked about, from OD maps, the intake form, and the sharing of information back out to all aspects of fighting this battle, the prevention, education, and treatment, and enforcement. And I think the one area that we all tend to, I don't want to say overlook, but I think is part of the prevention side, is education. And, you know, what are we going to do with future generations to look at the information we give them to process, and the training and the educations in schools to prevent this from happening down the road, I think would be important.
Got it. Ms. Ayala?
I believe that it's two-part. So the opportunity to discuss with our residents the issues of substance use disorder in the terms of public health and the overall health of the community have probably been the most profoundly liberating aspects of our work. The other is to acknowledge that the infrastructure for substance use disorder treatment is extremely limited.
Well, that transitions to my last question, which is, you know, the 2018 omnibus package appropriated $3.2 billion to address the opioid crisis. We're still trying to figure out exactly how that money is going to get spent, but at least in my understanding, I don't think it's going to be directed so much to DFC, drug-free communities, or the HIDA programs, more to certain treatment programs, which is also a huge unmet need as well. But I mean, what's your kind of impression of the amount of money that was appropriated, and you know, what are some of the unmet needs that we really need to address that maybe we're not addressing even in this package? Ms. Haskins, just down the row, very briefly, please.
You will never be able to treat your way out of this problem, regardless of how much money you throw at it. So unless you continue to fund and at additional funding levels, unless you continue to fund prevention,
right,
you will never have enough money for treatment.
Right. Thank you. Ms. Roberts?
I would have to agree with Ms. Haskins. It's been typical for a long time for most of the money to go towards these sort of downstream crisis problems and less money to go towards preventing them in the first place. And I think that's one of the reasons why we're seeing this crisis now.
Thank you. Mr. Siegel?
I would agree also, prevention. You know, once they get, we all say we can't arrest our way out of it, we can't treat our way out of it, and I think we need to avoid getting those people to that level because we've lost them by that point.
Thank you. Ms. Ayala?
And although I absolutely agree and support everything that's been said, I also don't think we can ignore this large population that now finds themselves ensnared in the chemical dependency. And so I would say we have some obligation as a civil society to address their needs.
Thank you. Thank you, Mr. Chair.
I would just add, I agree with all four of your responses on that, and just add this, and it's in regard to the Medicaid expansion. I think we cannot ignore this, that there has been a dramatic increase in addiction in the states that have expanded, and that we're better off, as each of you said, directing federal funding on prevention. We can't ignore the addiction issue either, that we've got to deal with that. But I think that we've also got to recognize that there's a problem, that we've created a problem with the expansion. And, you know, my previous career was with a think tank. Part of that was in engineering. And one of the things that we fundamentally understood is you cannot solve a problem until you properly define it. So with that, again, I'd like to thank the witnesses for appearing for your testimony. The hearing record will remain open for 2 weeks for any member to submit a written opening statement to questions for the record. If there's no further business, without objection, the Subcommittee on Health Care, Benefits, and Administrative Rules stands adjourned.
Look at our own. Yeah.